Okay, can we start?
Yes, madam.
Okay. Sorry. Okay, so today we are going to talk about hypoxic, ischemic, encephalopathy, right? That is a better term for birth asphyxia. It's the same lecture. Okay. So, before we go on to what we actually do, you need to understand what actually happens, how babies breathe, what happens if they don't breathe. So there were several experiments done on fetal lambs actually, who were taken out of rather a cruel experiment, but it was done a long time back. So the fetus was taken out of the uterus, and various things were done to see what happens if they don't take their first breath. So basically, like a bag of water was put around their head. They were suffocated to see for a while and monitor what happened. Right. So I think you know that the respiratory center controls the type of higher center respiration that we usually have. And if that gets knocked off, or if there is not enough oxygen to run that, the more complicated the control is, it needs more oxygen. If there is not enough oxygen, then can someone tell me what will take over? You learned respiratory physiology in the first year. I don't know whether you remember it. So respiratory center controls what we are doing now, but if there is hypoxia and if it stops working, do we have another rescue mechanism? I think we talked about this earlier. Is there nothing else in our body to stimulate respiration, or do we have another respiratory drive in the body other than the higher center in the brain? Yes, anybody? We have a spinal center, right? So if the higher center, the respiratory center gets knocked off, the spinal center gets activated, where while the respiratory center is working, it overrides the spinal center. So as long as respiratory center is working, like in all of us at this moment, spinal center will not be working. But once the respiratory center is not working anymore, then the spinal center takes over. So the spinal center breaths are gasping breaths, which are deep breaths, but they are much slower than the usual respiration. So if the oxygen is not restored, even then, right, and after a while the spinal center will also shut down. Then there is nothing else in that person's body to make that person breathe or the baby breathe. So unless somebody comes and gives artificial respiration, so then there is another way that they can get air inside the lungs. Right. So if a baby doesn't breathe, or if one of us don't breathe, what happens? Can someone quickly tell me? What happens when you don't breathe? In order for us to understand the next few slides, you need to know this part, right? So the sooner you participate, the sooner we can get on with this. What happens to oxygen?
It reduces.
Yes. What happens to carbon dioxide?
It increases.
Right, very good. And then if the carbon dioxide is increasing, if the carbon dioxide increases, the oxygen decreases. Now, if you remember your biochemistry days, you might remember that usually when there is enough oxygen, we usually use the aerobic metabolism, right, for energy production. But when there is not enough oxygen, in a state of hypoxia, we will switch to which metabolism? Yeah?
Anaerobic metabolism.
Anaerobic. That will be the byproduct.
Lactic acid.
Lactic acid. So therefore, if someone stops breathing, after a while, the oxygen will go down because there is no gas exchange. We keep producing carbon dioxide. Carbon dioxide will go up. And since we go on to the anaerobic metabolism, the acid levels will go up. Right. So if I start explaining to you the picture that I have shown in the slide, right? So this shows someone who has been regular breathing. And then for some reason, the breathing stops. Right. So now let's say in a baby, what we see is the baby is not breathing. So now here, if you look at these pictures, these are close together. Respiratory rate is high. So do you think these breaths, initial breaths, are controlled by the respiratory center? So these initial breaths, right, what you are seeing here are controlled by the respiratory center. So this is basically, I am showing you the slides from that experiment with the land, which we are using to understand what actually happens when a baby does not breathe, right? So if the respiratory center shuts down, then there is a period of cessation of breathing or no breathing. That is called apnea, right? So the meaning of apnea is there is no breathing. Now, primary apnea is the time when there is cessation of breathing from the respiratory center, right? And there is a time gap until the spinal center is activated. So the time gap between where the breaths are controlled by the respiratory center and the time gap between the onset of the spinal center, that we call primary apnea. Now this is all for learning purpose, right? So during this time, change to the laser pointer, you can see oxygen is decreasing, as your colleagues mentioned. And when there is no gas exchange, carbon dioxide is increasing. This third line is for acid. The amount of acid will also increase. Now you can see, now this is the first top one is for breathing, then you can see the heart rate. The heart rate initially rises. Now can you remember that hypoxia is one of the stimulants to increase the heart rate. But if there is not enough oxygen for the heart to function, then the heart rate will drop. Because all our organs need a certain amount of ATP and energy to function. So if without oxygen, that amount of energy that we need will not be there. As a result, the organ function will be affected, right? So the initial part, there will be only tachycardia, but after that, the heart rate will reduce. So now I'm sure you have had many obstetric lectures, right? And you must have talked about fetal tachycardia. And if there is fetal tachycardia, they take it pretty seriously. And they need to see why there is fetal tachycardia. That means the baby is distressed, right? So this is what happens. Fetal tachycardia means that there may be hypoxia in the baby and the baby is having problems and struggling. Fetal bradycardia is even more ominous, right? Because as you can see, fetal tachycardia shows you the initial part of the problem, where the problem is starting. But fetal bradycardia means it has progressed for some time. So intervention ideally should be done with the fetal tachycardia. But by the time you see if by any chance the woman is having fetal bradycardia, intervention becomes more urgent. Whereas with fetal tachycardia, you can maybe wait and see whether it's getting better or not. Right. So that's about the heart rate. Then if we look at the blood pressure, again you can see the blood pressure increases initially and then starts to go down. Right. So usually when we talk about blood pressure in a neonate, the blood pressure that we expect to be there in a neonate is equal to the gestational age. So if we say blood pressure in a term baby, right, should be around 40. If it's a blood pressure in a 36-week baby, we would expect around 36. Right, that's a rough way. So this is the blood pressure as in the mean arterial pressure, right? So that if you remember again in physiology, you have the mean blood pressure. There is a calculation how to get the mean blood pressure. It's calculated in the blood pressure machines. We don't physically calculate it, manually calculate it. And we look at the mean blood pressure, which is worked out from the systolic and diastolic pressures. Right. So the first instance is when a baby is, when the baby is born, baby is not breathing. So it may be that the respiratory center has stopped. and the spinal center has not yet taken over. Now next you can see the second arrow is placed. Again there are some breaths here, but these are deep breaths. If you compare to the previous breaths, they are deep breaths and they are taken slowly. That is a gasping type of breathing, right? So with the gasping type of breathing, if the baby does get gasping type of breathing, what do you think will happen to the oxygen? Sorry? Yeah, I need you guys to answer quickly. Now the spinal center has taken over and there are gasping breaths. What will happen to the oxygen?
Oxygen levels will go up gradually.
That's right. Oxygen will go up. What will happen to carbon dioxide?
Carbon dioxide will go down.
Down. Acid?
Also will go down.
Down. Heart rate?
As heart now has some oxygen, but still there is the hypoxic drive, heart rate will go up.
Yes, I think so too. And what about blood pressure?
Blood pressure will also go up.
Okay. How do I get this to work? Right. Okay. So, if things are restored, you can see if things are restored, it should have gone up. But let's say there is no oxygen, right? So there should be, depends on how much oxygen the baby gets during the gasping. So here only the gasping has been there for a while, but after that the baby has still continued to be hypoxic and that has also stopped. So now again there is no breathing. Now the initial cessation of breathing between regular respiration and gasping respiration, that is the respiration by the respiratory center and the respiration by the spinal center, is called primary active, right? So the cessation of respiration or the absence of breathing after cessation of gasping is called secondary apnea. So now here what happened was baby was hypoxic, no intervention was done. So the baby did not get oxygen at any point. But what your colleague said is right, because we were talking about a scenario if the baby was given oxygen, it could have improved. But here now these are the things that happened. So what they did was they kept the lamp out. They kept the lamb's head inside a bag of water and stopped that guy breathing and monitored what was happening. So initially there were few breaths, it stopped, then there was this gasping type of breathing, then that also stopped. So if no intervention is done, things will be like this, where the oxygen is going down, carbon dioxide is going up, excessive acid is going up, heart rate is going down, blood pressure is going down. If we do not intervene, the baby will die. Right? So why we are talking about hypoxia is, I think it has got inserted to the wrong place, is because it contributes to about 1/4 of neonatal deaths in the world, right? And if we look at Sri Lanka, we have improved our statistics. It contributes to 10% of deaths in our country. Oops, this has all got, sorry, wait, something has happened to my presentation. Just a second. Okay. All right, yeah, no, that's it. Huh? Right, okay. So, now that's what happens when the baby does not get any oxygen. So unless we do an intervention, the baby will continue to deteriorate and die. Right? So why we should not use the word asphyxia? Asphyxia means absence of pulsation. Right, and it's used in forensic medicine for deprivation of oxygen. But actually it's used for situations with mechanical asphyxia, where there is smothering, plastic bag asphyxia, choking, compression of the neck, positional restraint, drowning. So, I mean, these are like all things where people voluntarily has done something bad to the baby or whoever, and kind of caused no oxygen to that person, or there is chemical asphyxia. So this is why the term asphyxia should not be used, because it has a different meaning in the forensic term. So it is better to use the word hypoxic ischemic encephalopathy. So in these words, encephalopathy means that there is a brain injury which is due to a problem with oxygen delivery. That is the meaning of the word hypoxia. And the oxygen delivery is reduced most of the time due to reduced cerebral blood flow. So there is hypoxia, ischemia, and both those contribute to the hypoxic, the brain damage, which we call internal hypoxic ischemic encephalopathy. So impaired cerebral blood flow is mainly due to the placental interruption. Right? So the blood flow to the baby gets interrupted, and that in turn will cause this problem with hypoxia, ischemia, and encephalopathy. Right? So again, if we look at it, the better term for birth asphyxia is hypoxic ischemic encephalopathy. And in order to diagnose that, we should ideally have clinical and laboratory evidence of brain injury due to the hypoxia. So the evidence of acidosis should be there, because now we learned about why we talk about acidosis in this hypoxic situation. This is because when there is hypoxia, we switch to anaerobic metabolism. So the more hypoxia there is, the more time the child would have spent with anaerobic metabolism, and the more severe the acidosis would be. And we talked about the ABGAS score during newborn assessment. So if the ABGAS score is 0 or 3 at 5 minutes, that also is taken as evidence of hypoxia. Ischemia. In order to say ischemia, there has to be more than 2 organ system dysfunctions. Right? And to say encephalopathy, there should be neurological signs. So we'll get to that in a minute, why we say there should be more than 2 organ dysfunctions. So what causes HIE? It's either systemic hypoxia and reduced cerebral blood flow. So what happens in the fetus when the baby is hypoxic? So if the baby is not getting enough blood flow, it will cause redistribution of blood flow. So what happens here? So when the body is faced with a potential threat of reduced oxygen, the body starts shunting the blood. They start shunting the blood into the main vital organs. So the vital organs are heart, brain, and adrenal. That is called redistribution of blood flow. But this is at the expense of making the other organs hypoxic. So therefore the kidney, the liver, the bone marrow, the skin, all the other places which are not considered essential or vital, the oxygen from everywhere else will be channeled to the heart, brain, and adrenals. So this is why we talked about saying that in order to say that the brain injury was due to ischemia. So if the brain is getting ischemic due to hypoxia, so before that the other organs should have all got ischemic. So therefore we need to have, in order to prove that the baby had hypoxic ischemic encephalopathy, we need to prove that other organs, more than 2 other organ systems have got hypoxia. Right, so that is the reason that criteria was there. So with this, the baby's cerebral blood flow autoregulation is anyway low in neonates, and autoregulation is lost further with hypoxia. And what happens if autoregulation is lost? That means the systemic blood flow, blood pressure will be depicted in the brain. That means any change in the systemic blood pressure will change the cerebral blood flow. So if the blood pressure drops, then the cerebral blood flow will also drop. And if the cerebral blood flow drops, it will cause ischemic brain injury. So failure of adaptation to interruption of placental blood flow will result in, now if for some reason there is interruption in the placental blood flow, I'm sure you can think of many reasons, right? There can be redistribution of the cardiac output. That is what we talked about, that it redistributes it to the vital organs, right? So it tries to preserve circulation to brain, heart and adrenals. And it reduces the circulation to renal, intestinal, skin, blood flow. And it can sort of, if the hypoxia is corrected at this time, then baby might be less damaged. But if things don't correct itself and the hypoxia persists, right, the adaptive circulatory mechanisms will fail. Then the blood flow and the oxygen delivery to the brain will also be impaired. And with that, autoregulation is impaired. And then, as a result, reduced blood flow will cause cerebral ischemia. Right, so this looks like a complicated slide, right? But yeah, this is basically the mechanism of what happens. So when there is an insult on the brain, the first energy failure, which is called the primary energy failure, occurs within minutes. So it's very hard for us to prevent that part, rather than prevent the whole episode itself with better fetal monitoring, to make sure that we intervene before the brain gets hypoxic. Right? That day we talked about fetal Dopplers in the growth restriction lecture. Right? So if the growth restriction is not monitored well, baby will have brain damage with that. So that will cause hypoxia in the baby, right? Okay, so anyway, coming back to this, within minutes of the initial hypoxia, there is primary energy failure. And with that, there are several biochemical things that happen with the sodium overload. It causes cerebral edema, right? And several things happen. Then with the reperfusion, right? When the circulation is restored, so during this time, several free radicals are formed. So when the circulation is restored, it causes another level of damage, which is called the secondary phase. That happens between hours to days. So the earliest it has been documented to happen is within the first 6 hours of life, and it usually occurs between the first 6 hours up to 72 hours after insult. So the window period of 6 hours allows us to try and intervene in between the primary energy failure and the secondary energy failure. Right? So this is why therapeutic hypothermia or the cooling treatment, whole body cooling, is employed so that we try to reduce the basal metabolic rate of the body, basically shut down all the unnecessary functions so that the secondary damage done by the oxygen free radicals are reduced. Right, so the mechanism cell death happens with the primary energy failure, where the primary mechanism is necrotic cell death, whereas with the secondary energy failure, it's a delayed cell death, which happens with apoptotic cell death. So what you need to remember is, no one is going to ask you what biochemical reactions happen in the first one or the second one. You need to remember that there's a primary energy failure that occurs soon after the insult, making it very hard for us to do an intervention between the insult after the insult has occurred. But between the primary energy failure and the secondary phase, there is minimum 6 hours. So within that 6 hours, we have to try and intervene in order to minimize the secondary damage. Right? So this is again another illustration of the primary energy failure. So there are different mechanisms for primary energy failure. The insult occurs, there is primary energy failure with reduced cerebral blood flow, reduced ATP, acidosis. All this damage happens with the excitotoxic neurotransmitters, right? And there is calcium entry and there is cell death. Then after the perfusion is restored, all the free radicals and things come, and there is secondary damage with the oxidative stress. Right? There is a latent period of 6 to 72 hours actually. Different pictures will say different things where we can intervene. So if we don't intervene, it will go on to the secondary energy failure where the blood flow increases but the ATP is less, and all these excitotoxic neurotransmitters will increase cytotoxic edema. There will be several inflammatory mediators which were formed, so they will spread all over the brain and they will cause cell death. So this is why we want to sort of reduce metabolism and reduce the blood flow and keep it in a latent state to prevent all the inflammatory mediators and the products of oxidative stress being circulated in the brain. And then years after, there can be tertiary brain damage, where you can see there can be a deficit in myelin, reduced plasticity, and even altered cell number. So this hypoxic damage that occurs at the time of birth, if not intervened within the given period, by intervening we can reduce the damage, but we cannot say that we can prevent the damage entirely. So the best thing is prevention, but we can minimize the damage by intervening within the first 6 hours, 6 to 72 hours, right? If not, there can lead to a lot of problems. So how does the brain minimize the temperature? By dropping in brain temperature and releasing of neurotransmitters such as gamma-aminobutyric acid transaminase, which is protective. So if you look at the biochemical mechanisms of HIE, you can see the hypoxic ischemia happening, leading to anaerobic glycolysis, right, which reduces the ATP, reduces the glucose, and increases lactate production. So reduction of ATP will lead to various, pathways, either by increasing glutamate through the NMDA receptors, can cause free radicals because of the free fatty acids. It can cause free radicals to the nitric oxide pathway, or it can cause free radicals to the xanthine pathway. So there are actually many research going on about, stopping things midway by trying to inhibit at various levels by using certain drugs, but they are not really still in the stage where it can be used in humans, many of them. Right, so there are many biochemical changes. You don't need to go through this. It's just to show you that so many things are happening in the brain when it faces with hypoxia. Right, so I think it's important to know that excitatory amino acids play a big role. And out of all the amino acids, glutamate is a major excitatory neurotransmitter in our brain. Right, so it acts through all these receptors, and it causes increase in sodium, calcium, and through this it causes a lot of damage in the brain, right? So we mentioned this, that it's responsible for 23% of all neonatal deaths worldwide and 10% of neonatal deaths in Sri Lanka, and it's one of the top 20 leading causes of burden of disease in all age groups by the World Health Organization. And it's the 5th largest cause of death of children younger than 5 years. So children who have faced with hypoxia at birth are at higher risk of cerebral palsy, mental retardation, and learning difficulties. So the damage that happens with the hypoxia can be graded, right? So it can be mild, moderate, or severe. So these different grades have a classification called the Saranath and Saranath staging. There are other classifications as well. You don't have to know each part, but you have to know the general way of how to diagnose, what criteria is there to diagnose mild, moderate, and severe, because the prognosis is different in all these situations. So in mild, the muscle tone is increased, tendon reflexes can be increased. There will be transient behavioral abnormalities like poor feeding, irritability, excessive crying, sleepiness, and it usually resolves in around 24 hours. But these babies present with feeding difficulties, right, which can last more than 24 hours. So moderately severe hypoxic ischemic encephalopathy presents with lethargia, with hypotonia, diminished tendon reflexes, where the grasping, Moro reflex, sucking reflexes are reduced or absent. There can be periods of cessation of breathing, apnea, because the respiratory drive is still hypoxic. Seizures occur early within the first 24 hours of birth. Full recovery within 1 to 2 weeks is possible, and if full recovery happens early, it is considered to have a better long-term outcome. So then you get the severe hypoxic ischemic encephalopathy, which is the most serious one out of the lot, and prognosis is poorest, right? So stupor or coma is typical. The infant may not respond to any physical stimulus. Breathing is irregular, tone is less, reflexes are absent or depressed, right? So these babies are unable to suck or swallow. Moro is absent, so you can imagine feeding is going to be a problem. They will have to be tube fed. They are at high risk of aspiration because their reflexes are not working. They may have other abnormal neurology like nystagmus, loss of dorsal eye movement, all that. Their pupils may be dilated, fixed or poorly reactive to light. Seizures are delayed and can be severe and can be resistant to conventional treatments. They have irregularities of the heart rate and blood pressure, right? And it is common to have death in the cardiorespiratory failure. The level of alertness improves by day 4 to 5. Hypotonia and feeding difficulties may persist, and they may require tube feeds for months. So this is actually the kind of condition which will give rise to severe maybe spastic quadriplegic cerebral palsy. So this is what I was talking about, the Saranath staging of HIE, where you can see summarized what we talked about separately, right? So in grade 1, the baby is hyperalert, grade 2, baby is lethargic, grade 3, baby is comatose. Muscle tone is increased in grade 1, whereas it is decreased in grade 2 and grade 3. Seizures are not found in grade 1. So if there are seizures, if the baby is hyperalert, tone is increased, it is grade 1. If the baby is otherwise well, if the baby is getting seizures, it should be definitely at least grade 2. If the baby is comatose, it should be grade 3. So the pupil reaction is different in different types of different severities of hypoxic ischemic encephalopathy, and respiration also changes, right? So as you can see, the babies with grade 3 usually will need to be in the ICU with ventilation, with lot of support for feeding, all that. Right. So we talked about how other organs are affected, because blood flow is taken from other organs, the oxygenation, right? It will be diverted to the heart, brain and the adrenals. So therefore, if the oxygen supply is not restored, the heart will also suffer before the brain, and they may have evidence of ischemia. So we need to prove that 2 other organ systems have ischemia in order to say that the baby is having hypoxic ischemic encephalopathy. So the heart is affected in 43 to 78%. It may present as reduced myocardial contractility, severe hypotension, passive cardiac dilatation, and tricuspid regurgitation. The lungs are involved in 71 to 86%, where severe pulmonary hypertension may require assisted ventilation. Then the kidney is involved in 46 to 72%. And the renal failure, which presents as oliguria initially, can end up with, it can change to high output renal failure during recovery. The liver is involved in 80 to 85%. and you will see this with elevated liver function. So if it's really badly involved, it will go on to liver failure. Again, hematological disturbances are seen in 32 to 54%. Right? So disturbances include increased nucleated red cells, neutropenia, neutrophilia, thrombocytopenia, as well as coagulopathy. So the easiest things for us to check would be the liver and the kidney with AST, ALT levels, where the AST is higher than ALT in ischemic conditions, and also by looking at serum creatinines to check for renal function. So when we talk of investigations, we need to demonstrate hypoxia. So a cord blood gas would show us whether there is acidosis or not, which would be needed for diagnosis. Grade 1 HI babies usually are in the ward, and we find them only during the neonatal examination when the tone is high. So since we are not doing cord bloods for all babies that are born, in these babies, we will not have a cord blood. But if the baby is sick and baby doesn't cry at birth, then in those babies, cord blood will be done. And we will be able to find whether there's acidosis. Then we have to check for different organ functions, because as you saw in the previous slide, all the other organs are getting ischemic. So we would need to check liver function, renal function, coagulation profile, as well as the cardiac enzymes. We would also need to confirm encephalopathy. So we need to do a neurological examination clinically. We can do an amplitude EEG, as well as we can image the baby. So among imaging, ultrasound scan is the most accessible one, whereas MRI is the most sensitive one. So what will we see? We may see involvement of the white matter, right? As well as involvement of basal ganglia or thalami. So involvement of basal ganglia or thalami indicate a poor prognosis, whereas white matter involvement indicates a better prognosis. So management involves reducing the damage, right? So cooling treatment, which we will get to in a little while, there's no need for you to know the details of cooling. And there should be supportive management. So there are things that make the hypoxic damage worse. There are things that can make the cerebral blood flow even less. So this, you need to remember the things you learned in physiology. What are the things that affect the cerebral blood flow? So if the carbon dioxide level is low, it will cause constriction of the cerebral vessels. So that is why we have to avoid hypocapnia, right? And we have to maintain the saturation of oxygen more than 95% to avoid pulmonary hypertension, because we said when the lungs get ischemic, there can be pulmonary hypertension. That day we talked about during the respiratory distress lecture, that if there is not enough oxygen for pulmonary dilatation to happen, the pulmonary vessels go into constriction and will cause pulmonary hypertension. So we must make sure the airway breathing things are maintained so that we avoid further pulmonary hypertension. If the baby is, say, let's having apneic episodes or periodic breathing with rising carbon dioxide and respiratory acidosis, the baby will have to have respiratory support, right? And we should have arterial access to monitor the blood sugar. We should aim for a mean blood pressure to be more than 40, because we saw that autoregulation fails with hypotension, and that if the systemic blood pressure falls, so will the cerebral blood pressure. So we need to monitor circulation. We need to consider volume support with 0.9% sodium chloride, 10 ml per kilogram over 1 hour, after which inotropes need to be considered if the blood pressures are not picking up. So if there is anemia, that will be further reducing the oxygen carrying capacity. So we need to check whether there is coexistent anemia and maybe correct it. So with regard to fluid balance, we usually restrict the fluid in babies with hypoxia because they will not be moving much. Their basal metabolic rates are low. We don't want them getting edematous, and we don't want to worsen the cerebral edema that they are having because of the hypoxic injury. So we start off with 40 ml per kg per 24 hours, whereas the usual amount of fluid if a baby needs IV fluid would be 60 ml per kg per day in a term baby. We have to maintain normoglycemia because both hypo or hyperglycemia cause further injury. We have to maintain urine output because we said that now all these problems are because all the other organs have got hypoxic. So in order for this baby not to go into renal failure, we must maintain the urine output. So there are many ways of doing that. You don't need to know details. You can use inotropes. So some inotropes at a low dose can cause increased renal perfusion, as is the case with dopamine. If there's a fluid hypovolemia, we can give a fluid challenge with furosemide, which is followed by a furosemide infusion. So we need to monitor for the multi-organ failure with various coagulae like we mentioned earlier, for renal failure, hepatic failure, calcium, magnesium, necrotizing enterocolitis, which is a condition which happens when the gut is ischemic, is common. So we should feed these babies only with human breast milk, not with any other type of milk, because any other type of milk further increases the risk of necrotizing enterocolitis. So we have to maintain temperature, but we should avoid hypothermia. Antibiotics should be used if you are not, because the risk of an infection causing all these problems are always there. But when we are using antibiotics, we should make sure that we are not using something that can increase the nephrotoxicity. Say, usual policy of antibiotics. Can someone remember what are the first line antibiotics in a neonate in early infection? Systemic infection, if we are using empirical IV antibiotics, what are 2 antibiotics we start?
Penicillin and gentamicin.
Yes, very good. So, gentamicin is what type of antibiotic?
Aminoglycosides.
Right. So one of the major side effects of aminoglycosides are renal failure, right? So we saw that these babies are anyway at high risk of renal failure. So if we are using, but the problem is coliform sepsis is also a problem. So if we are using, we have to be mindful and we should be checking the level. So else we should maybe avoid using aminoglycosides and use something else for the gram negatives. So you have to neurologically monitor these babies. These babies, if they don't have swallowing reflex, all the secretions will get collected and there will be high risk of aspiration. So we will have to regularly suck this baby. We have to check whether the gag reflex is present. If the gag reflex is not present, there's high risk of aspiration, which will mean we will need to secure the airway. So we'll have to check the pupils because we said in order to look at the Saranad staging, pupils were one of the criteria, right? They can have tongue pacificulations, abnormal movements, presence of seizures. We need to check we also need to check when the first signs of recovery are being made, because that will mean the baby is improving and that can help us with deciding on the prognosis when we are speaking to the parents, right? So a baby who never really gets spontaneous sucking movements or eye opening and doesn't respond, the prognosis is extremely poor. So the problem is now when babies are hypoxic and if we start the cooling treatment, we have to sedate the baby because it's extremely uncomfortable to be cooled while you are awake. So when you do this, you will not see seizures. So therefore, it's important that we have an EEG machine connected to the baby to identify the seizures. So we talked about the staging earlier, but this will also show you what the outcome is. Right? So in stage 1, which we call mild hypoencephalopathy, mild HIV, symptoms should resolve in 1 to 2 days, and the neurological examination would be expected to be normal in 1 to 2 weeks. The outcome can be pretty much normal. Stage grade 2 will have abnormal EEG and seizures are common. That's the most outstanding feature. 25% are at risk of getting cerebral palsy. If you get severe HIV, They will have very abnormal EEGs with suppressed background activity, and the outcome would be death. So this is just a picture for interest. When we connect the amplitude EEG to these babies, so when we start the cooling treatment, we connect it to look at the EEG pattern. Right? The usual EEG should have sleep-wake cycles. That is why in the first one you are seeing areas where it is thin and where there is waking up. Then that is the normal EEG, right? So the lower border should be more than 5 microvolts and the upper margin should be more than 10. Moderately abnormal is where the lower margin is lower and the upper margin is high, and you get a very broad trace, right? And severely normal ones would be, you can see that also with this you can see burst suppression where you get periods of zero activity with lots of activity. So that's burst suppression. Then the even worse state is when there's very poor activity in the brain, and isoelectric activity of the brain means basically there is no activity. So this is what you see, and this will help you with prognosticating and also deciding into which category the baby belongs and what sort of management it needs and what we can tell the parents when we are talking to them. So here you can see different types of EEGs with sleep-wake cycling, and neonatal seizures where you can see the pattern changes. So here it's suddenly there's a spike. Here there's a big spike. So these are all places where seizures are occurring, right? So by keeping the EEG, that is what we said, by keeping the EEG, we can see whether there are seizures, although muscle movements are not. So here you can see there are continuous trace. There's a continuous trace of seizures. There's no return into background activity like in the previous slides. Here there's a seizure and there's a normal period. Seizure, normal period. Seizure, normal period. But the next slide, which I showed you, shows the status epilepticus. So these are important with deciding what kind of anticonvulsant, dosing, increasing doses, all that in managing the seizures, right? So sedation and paralysis, which is needed when we are doing the cooling treatment, makes it difficult to assess. And seizures will be missed. That is why continuous cerebral function monitoring is needed. So children who can feed well and fix and follow by the end of the first week are likely to have a good and normal outcome. Children who can do that by 2 weeks may be well, but they can have issues with their basal ganglia, and which can later lead to athetoid type of cerebral palsy. But they will have preservation of intellect with head growth. Children with adequate feeding after that in 2 to 3 weeks may have further problems with maybe issues with visual attention and white matter injury, which can lead to microcephaly and some slowness in learning, which may not be associated with a major motor deficit. So cranial ultrasounds are done regularly. You can see 24 hours, 3 days, 7 days, 14 days, which can show you a couple of things. Again, details you don't need to know, but you may be able to see swelling, right? We talked about cytotoxic edema. So first thing is you do one as soon as the baby is admitted, once you stabilize the baby, because you want to know whether the baby was born with a structural malformation, was there ischemia at the time of birth, was there hemorrhage. So to check all that, you should do first one at 24 hours. And if the problems are due to then you will also want to identify, in addition to the background problems, what has happened due to the hypoxic ischemia. So there can be swelling, because we talked about cytotoxic swelling, which happens after the first injury. And then over time, this is why we keep repeating it every week, right? With ischemia, the white matter damages show with hyperechogenicity. And we said, if you remember the places where we should look are in the white matter. So that is the periventricular area on either side of the lateral ventricles, as well as we have to look at the basal ganglia and the thalami. We said if the basal ganglia and thalami are seen, that means the prognosis is not very good. So these are some pictures just for interest. You definitely do not know how to interpret them, but you can see the normal. We've shown you the normal one, right? And then you can see there is the lateral ventricles have narrowed. Here you can see some blackness here. But here they have narrowed and everything is opaque. This is the picture you see with cerebral edema. Here you can see around the ventricles, there is hyperechogenicity. We call it periventricular hyperechogenicity. So that is another way of knowing that there is white matter damage, predominantly white matter damage in this baby. So again, blood flow velocity. We talked about this, right, a little bit with growth restriction. You can see with mild HIE, the blood flow is there somewhat. It gets reduced with moderate HIE and it's very low in babies where there is severe HIE. So ultrasound scans done later will show loss of brain matter. When there is loss of brain matter, the ventricles will take up that space and appear dilated because of the atrophy of the brain parenchyma. And you can see the cystic formation near this is the lateral ventricle, and you can see these black areas outside the lateral ventricle because of loss of brain matter. So these would be permanent changes in the baby, which will say that the prognosis is that the baby is going to have issues. So in summary, like when you talk about treatment, you have to avoid many things. You have to avoid hypothermia. You must avoid poor perfusion with volume replacement if needed, inotropes. You have to avoid hypoglycemia. You should maintain electrolyte balance, and you should anticipate and treat seizures. So the only therapy which has been unequivocally found to be helpful in these babies is therapeutic hypothermia. So what decides the outcome? Duration, severity of the initial insult combined with the effects of reperfusion. So what shows poor prognosis? If there is poor respiratory effort within the first half an hour. Seizures, if the baby gets abnormal neurology within the first 10 days, persistent feeding difficulties, poor head growth, all these would indicate poor prognosis, right? So this is a picture of the machine. So when you come to the appointment, you can maybe see the machine. We have this machine and we are doing cooling treatment. Started last year. So we have the EEG, and during cooling treatment, that is the only time we, insert a rectal probe to monitor the temperature, because with cooling treatment, we need to keep the temperature between around 33.5, right? Severe hypothermia and persistent hypothermia is also, it will cause further worsening of the baby's condition, because when we make the baby cold, several body systems are not kept in a physiological range. So the longer we try to cool the baby, there will be more problems with hypothermia, coagulation problems. The baby is more prone to bleed when you are cooling. So this is why we start cooling within the first 6 hours, right? And then we have to stop cooling within 72 hours. If the prognosis is very bad, but since in our country the problem is we don't have any laws in place for discontinuing treatment, so therefore when we start something, we have to continue it. So here is a closer picture of a baby receiving the cooling treatment with the cooling blanket, right? So you can see on top, so the blanket is what you can see, which is wrapped around the baby. So we do this treatment at present in our hospital. But you can see this baby is very sick. Can someone point out what devices are attached to this baby? So this is the cooling blanket. What is this? Looks like a endotracheal tube or something. Various cannulas, various things, and these would be the EEG leads on top. Right? So to prevent disability in these babies will need multidisciplinary care, which would involve physiotherapy, occupational therapy, speech therapy, also maybe therapy for learning disabilities, and we need to support feeding. So long-term follow-up is needed with regard to neurodisability, development, cognitive function, as well as growth. So in order to prevent this problems from happening, we have to ensure that the babies get good antenatal care with good quality resuscitation. The previous slide was about that the trials. There have been 11 randomized controlled trials, including in a systematic review with 1,500 babies, that therapeutic hypothermia is beneficial for late preterm newborns, term and late preterms with hypoxic ischemic encephalopathy, and the major improvement is seen with the babies in moderate encephalopathy. Right, so that is based on that is the reason why hypothermia treatment is used. Okay, any questions?
Madam, are seizures more commoner in stage 3 of hypoxic ischemic encephalopathy or stage 2? The first table said that it was uncommon in stage 3 and later the table said that it's common.
So that's a small discrepancy there. I mean, it depends. I don't think we need to split hairs on that. Seizures can occur in both, but as a diagnostic criteria, it's usually used in 2 because those babies are a little alert, but they are having seizures. But no, I don't know why those two tables say different things, maybe from 2 different sources. So I don't think anyone is going to ask you a question about whether it's commoner in one or the other. But what I can say, seizures are seen in 2, but seizures are definitely can be more severe and resistant in 3. So I think my mistake. I have taken it from 2 places. I should remove that part where there is more common. That I do not know. 3 also we see seizures a lot actually. So I'm not sure whether we can say it's commoner in 2. But the issue is seizures are taken as a diagnostic criteria in 2 because in 3, I mean, if you have seizures, you can't say for sure whether it's 2 or 3. But being comatose and having poor EEGs and all that will tell you it's 3.
Thank you.
Okay, good observation. Anything else? Okay, so if there are no other no other questions, we can end it. And I think one of you had shared an email. I will send the PDF forms of all the stuff I did onto that.
Thank you, madam.
Okay. Okay, so have a nice day if you don't have any more questions. Please make sure you keep, at least go through the stuff before you come for the pediatric professorial as well, right? You will need this stuff, not only for your module, but for the later pediatrics part as well.